Okay, so the first thing we think about, which is not something that is really commonly understood in the physiatry community, is which part of a spinal cord injury is upper motor neuron and which part of it is lower motor neuron. And so just to kind of give everybody an understanding here of at the site where our spinal cord is injured, at the site of trauma where it's crushed or if it's ischemic or whatever else, the part of the cord that is the most sensitive is the center part. And the spinal cord is sort of opposite of the brain. On the brain, the gray matter is on the outside, the white matter is on the inside, and then we sort of reverse as we head down the spinal cord. And the white matter, so those fibers that are passing by this region to go to something below, they're on the outside, and the gray matter is on the inside. And what's in that gray matter is that motor neuron and his axon. So think of this as the individual, and this is his arm that reaches out of the spinal cord, and he makes contact with skin and muscle. And so when the gray matter gets destroyed, this individual neuron is destroyed. His axon vacates the entire peripheral nerve, and that muscle begins to die off. Now, in this patient, whatever nerves are associated with this segment are the ones that are going to die off. Those muscles will atrophy. And that's why a number of patients that come out and say, hey, we really got to get this done fast. The nerve transfer surgery, because after about 15, 18 months, they become irretrievable. And so nerve transfer is no longer an option. Everything connected to this healthy looking spinal cord below the injury is still viable. But that's the part of the cord in a complete injury that's causing spasticity and tone you don't want and movements you don't want to have and the tightness and so forth. That's because this part of the spinal cord, which is healthy, can't talk to the brain anymore. And so all it's doing is reacting to the sensation that comes in through the other part of the nerve. So if you get a pressure sore, you have a full bladder, whatever, those spasms get worse because he's looking for somebody to talk to him, and he's going to react to whatever input he gets, which is no longer coming down from the brain. Now it's all coming in from the sensory nerves that are connected to the spinal cord below the injury. So that area of lower motor neuron, or that area that causes the atrophy in the arms, is very dependent upon the type of injury somebody has. So if it's a really discrete injury, like you herniated a disc right here and we compress the entire cord, there's not going to be a lot of denervation of this one. The arms will be full, they'll look good, the musculature will be okay throughout. And this person probably could have nerve transfers 10 years later and hasn't lost anything. The one on the right, though, we've got hemorrhage into the spinal cord. And when you see damage in the cord, it's going to preferentially get the stuff in the middle, which connects to the nerves, which connects to the muscles, and the muscles waste away. And so, and we run over this over and over again, but that gray matter is what gets destroyed. It's just like our nerve injuries. But everything below the injury, even though it's paralyzed, these nerves below the injury are normal nerves connecting to normal muscle. They're just looking for somebody to talk to them. So this is our quick discriminator. And if you have a lot of sensation down low, you hate it. But if you don't mind it too badly. And this is a little cheap device that the anesthesiologists use in the operating room to make sure when they've given the medicine to relax the body before surgery, they use this to test, is everything relaxed? If this activates a muscle,
can you turn up the heat to 69, please?
If this activates a muscle, it means this patient or that muscle, even if it's been years since surgery, is going to accept a nerve transfer. So a patient who has no finger extension, we can hook this up and just turn on the stimulator and see what happens. If the fingers go up like this, we say that is what we have access to with a nerve transfer. We can see these muscles can turn on, they can drive that kind of strength and finger extension. And so if I can find a good nerve to connect to that nerve, we can make that happen. You can have control of that once again. If on the other hand, we put these on and we go full blast and we never get anything out of it, then we say that muscle has been degenerated. That's that part of the spinal cord I was talking about where the gray matter was lost. And that muscle, after about 18 months, becomes an irretrievable muscle. Now, it doesn't mean there's no options on the table. And there's a number of people that have visited me and I said, hey, you're not a candidate for nerve transfers, but there's other things we can do. And a lot of folks walk away after that and said there was nothing he could do. There are tendon transfers, there are muscle transplants, The other options are a little bit more involved, but there certainly are still things that can be done if that's the case. So, and this is what a typical arm that has that type of injury associated with it looks like. You can see the hollowing of the hand. You can see the bones in the hand. You can see the atrophy of the forearm, and the only remaining muscles really stand out from the rest of the forearm there. And you can say, hey, that is one where the muscles have degenerated. But this patient is a perfectly good candidate for tendon transfers. You can see which tendons are available right there. He's got his pronator teres, which can go into finger extension. He's got his wrist extensors available, and that can go into finger flexion. And we can still make a functional hand with that, but we can't use nerve transfers in this case. So here's the strategy for nerve transfers in folks that are chronic. So if you've had the injury more than a year and a half or 2 years ago, we just need to make sure that the muscle below stimulates, and we connect a nerve from above the injury that you have control of to a nerve below the injury that you don't have control of. And then these wires have to grow down here, and nerve regeneration takes place at 1 millimeter a day. And so that's why from the time we hook it up, I say it's like planting a garden. It's going to take a little while for this to get down to the muscle, begin to sprout, and recovery begin to develop within that muscle. And so often it is 9 months before we see that movement. We see it sometimes as early as 3 to 4 months, and sometimes I've seen it as late as 15 months. So we hook it up and then just wait for the body to heal itself. And there's a whole lot less rehab involved than with the tendon transfers. So this is a patient, kind of a typical C5 injury. So you guys are all familiar with this. No hand function, the wrists go up, the biceps flex, the shoulders work, the triceps are not stable. And so you try to reach hands above head, and they come swinging in. There's no stability there. Can only hold a pen because that grip are wrapped around the left hand there. And so, if we can fix those things, I feel like it gives people a dramatic increase in quality of life. So the goal is, and again, if this gets too technical, please do stop me and clarify. But the goal is we always want to take something that nobody's going to miss, because we certainly don't want to add new weakness on top of weakness folks already have. And that is, when we started this practice, people were terrified. You're going to cut a good working nerve, hoping to get something better. Clearly, you're stealing function they already have, and I don't have much. Why would you do that to me? And here's how we can do that. So we rely on our EMG test a lot. And the EMG test will tell us the health of both of these muscles, which do the exact same function. So when we're targeting the triceps, we often use shoulder external rotation. I don't know if you can see me, but that ability to turn the arm away from the side of the body like this. Both of these muscles do that. Both of them are high C5 muscles, so they should both be preserved in most cases of mid-cervical spinal cord injury. So I can take the nerve branch to this one, and we do lose that muscle, but this one is so much bigger, does the exact same function, that folks will not notice that loss. And we've gone back and interviewed people and said, do you see any difference in your shoulder function afterwards? And the answer always is no, we do not see any difference. So I can take that muscle, we leave the function intact, I can take his nerve and send it downstream to a much lower muscle, which is the triceps in this case. And so this is, again, the trade-off. We're taking a nerve branch to this muscle right here, and we want to send it to this muscle right here. And that's what that looks like. So now that one's gray, and this one turns red, and that external rotation becomes elbow extension. And in a high cervical spinal cord injury, we often have to go all the way up to the elbow flexors to get the finger flexor power. And so we put a graft here, and we run that down to the hand, and that's where the finger flexion or hand closing is going to come from. So I don't know if you guys want surgical videos or not. Some people don't like that. So I'll move along unless there's a request to see it. But this is the triceps branch. This is the axillary nerve. That one there is the branch that we're going to connect to that branch. And this is the very first patient we did this for in San Diego. And here is the arm we did it to, and she just discovered on her own how to do it. So she had no elbow extension whatsoever on that side. We used that external rotator, and she learned at about 15 months after the surgery how to do that. And there is no retained connection with external rotation. She's got great external rotation strength. It doesn't send her arm into elbow extension. And then she can extend the elbow over her head, and it doesn't send her an external rotation. Her brain did a beautiful job of remapping those functions. And somebody asked me a question, so pause for a second here. So nerve transfer is when you take a nerve from above the injury to use in an area below the injury. That's right. It takes a nerve branch that you have control of, and it connects it to a target that you currently don't have control of, so you can get a new function. All right, so here is this lady again. Now, we saw her before because she really couldn't stabilize her arms, and she got the transfers on both arms for fingers and for triceps, and now she can get her arms up over her head.
Extend.
And of course, the folks who make the presentation are always the better than average. So I never want to promise you that everybody gets a result like this. In fact, we ran through and we've been putting together our results and here, what are the last 30 or 40 arms that we do? What were the outcomes on it? And I would say probably 40 to 50% got this kind of arm that could extend straight up over the head. The other almost 50% couldn't quite do this. They could balance the arm in order to extend it over the head. They could straighten themselves so the elbow locked out to raise it over the head. They could right themselves for pressure releases. And they actually gave us very favorable outcome, responses. I'm glad I did it. I would do it again. It's been very helpful. When we had rated them as this is a failure because you're not reaching overhead. So reaching overhead was about half or maybe slightly less than half the patients, but everybody got some ability to extend the elbow. And even if they didn't reach overhead, stabilizing themselves, balancing themselves, reaching the space in front of them seemed to be a big deal. So that's how the triceps have gone. Now, when you have triceps, or even when you don't, getting the hand to work is sort of the number one deal here. We've got to get the fingers to open so you can get around the object, and then you got to get them to close so you can grasp that object. We want you to be able to hold a pen, feed yourself, catheterize in some cases. And what people do need to understand is this is not a normal hand we're creating here. We're using spare parts to get everything we can get. And so when we get it, those fingers, they all move together as a unit. And we're only getting the most important muscles to achieve a particular function. And so the balance of a normal hand that has all the small muscles inside the fingers and a whole set of muscles that go to the proximal joint, muscles that go to the distal joint, muscles that balance those aren't there. We're just turning on the most important of the set. So this is the one to make the hand open. And the most common operation we do is supinator. So the branches here to this muscle, which turns the palm from facing down to the floor to up, so facing up to the ceiling, that movement is referred to as supination. And this red muscle here, which turns gray there, is a primary mover to make that rotation happen. The other muscle that does that is your biceps muscle. Because the biceps muscle does that, we can get rid of the supinator muscle, and folks, for the most part, don't notice the loss. You would notice the loss a little more, and we've been measuring people's strength and twisting their hand up before and after surgery. When the elbow is fully extended and the arm is straight out in front of them, there's a measurable decrease in strength of twisting the hand up, but they can still do it. So that's been a fair trade-off. When the elbows are bent, the biceps almost does the entire job. And so most of the working space in front of you, in a chair, at a desk, there really is no loss in turning the palm up, supination. So we can steal those two branches and we put it into this nerve, which feeds all the extensor muscles of the hand. So this is going to turn on bringing the thumb out to the side, bringing the tip of the thumb back, bringing the fingers back. So without these little muscles in the hand that balance it. And so that's the operation. I won't go too far into that. And with each of these procedures, you have to go through a period. Usually, some folks just figure it out automatically, but usually you have to go through a period of a therapist teaching you how to activate. And so this is one of the patients. Some of the folks initially came from a long distance. I would coach them through everything they need to do. They may come back a year later and say, gee, really nothing ever worked. And I say, well, let's test that theory real quick. I'm going to grab you by the wrist and you try as hard as you can to twist your palm up towards the ceiling, and let's see what happens. And so he twists his arm up towards the ceiling and, hey, wait a second, I actually can open my fingers. And then once that discovery is made, usually it's not very long. Sometimes it's even within that clinic visit that by the end of the hour, they're doing that without twisting the palm up. I would say more often it takes a few weeks of working at it before they can separate those functions out. But then, hey, I can open the hand, and that's been a great transfer. The tendon version of this, there's the old orthopedic surgeons who've been doing this since the 70s like to come and argue with us and say that their procedures are better, and we say our procedures are better, and sometimes it's a balance between the two. But this nerve transfer, they all agree our tendon transfers don't do this. They're not as effective as getting the thumb out and getting the fingers to open and so forth. So this one is a hands down a winner compared to the tendon transfers. Finger closing, we're still a little bit of a tighter battle, but this one wins. And here's a local gentleman who had a C7 injury before surgery, no ability to open the fingers at all. And then after surgery, the fingers come up just fine. Now you'll notice when the fingers come up, and this is really common, you see that position of the finger? It hyperextends here at the knuckle, and it remains flexed out here. And that's a really common thing to happen. It's not everybody, because some folks retain a lot of spastic muscles in here, but those who don't retain those spastic muscles, they get an imbalance, and it's referred to as a claw. We encourage folks after the strength comes to get a second procedure, which will bring those knuckles down. And once you bring the knuckles down, that will translate into the tips of the fingers coming out straight. So if we can stop this knuckle from coming all the way back to here, if we can stop it at the straight position, the rest of that pull makes the fingers here go straight. And there's probably folks in your group that have had that procedure done, but it does seem to help a lot to do that. So I always talk about, we're going to do nerve transfers, but after you get all your function back, we do want to probably tune this up and make sure everything lines up and gives you the best function that we can get. And just more examples of the same thing. With nerve transfer, we sometimes cannot anticipate, particularly in the chronic population, which fingers will get the best function and which ones will be weaker. So you can see he's much stronger in these last two fingers than he is in the first three. And this one, if we did that procedure, we would just do it to those two fingers on the ulnar side, because the rest of them come up reasonably straight. So we did just publish a series of hands and to show kind of the spectrum of outcomes here. And here's one that maintains the muscle tone within the fingers, and therefore the knuckle comes to just beyond straight here. And then what we refer to as the IP joints or interphalangeal joints then straighten up nicely. The thumb aperture is the critical piece here. You got to get the thumb out and away from the hand so you can get around that cup, you can get around whatever, your cell phone, to pick it up. That thumb aperture was really critical. This is one that really doesn't have any of the muscles there, so a dramatic hyperextension that needs to be corrected. This individual had a lot of spasticity in what we call the hypothenar muscles that pull that knuckle down right there. And so even though he had reasonable strength, these fingers didn't come up because of that. And that's one that later on we would want to either apply Botox or actually denervate that muscle so these will straighten up better. And then we did have a subset where the ulnar digits got great strength, but the thumb and index really never got the kind of strength we wanted to. And so for those, we often save a tendon transfer later on that we can use to pull the thumb up better and make sure we get a wide aperture of the thumb away from the hand so we can get around those objects. So the good part of this is getting that thumb out and away from the hand, we had 83% success rate. And getting the knuckles to fully extend, we had a 94% success rate. So it's less than a 3-hour patient, and this is really much better than the tendon transfer outcomes. So the procedures we have really are kind of based on level to get the fingers to flex. So that's the finger opening procedure. It's what we do almost across the board if those muscles are available. If they're not, we have to do the tendon transfers. But now to get the fingers to close, in a C7 injury, when the pronator, or the opposite muscle that turns the palm from the up position to the down position, when that's available, that's nice and straightforward, because you say, hey, you're going to turn it up to open the hand, you're going to turn it down to close the hand. It's sort of easy to conceptualize that transfer. And it's right there. It's a very simple operation. And those hands tend to be some of the strongest we have, is those two transfers. As you descend in the spinal cord, as you get up a little bit higher, now you're a C6 injury, that becomes too weak to use. And then we have to use a wrist extensor. We have usually two in the C6 injuries. We have one, both of them are kind of on the radial side of the wrist. So most folks have a cervical injury when the wrist comes up, it sort of comes towards the thumb as it comes up. There's two muscles that insert down there. We have to test to make sure both of them are available. And if they are, we can take the nerve to one of them, and that goes to the fingers. So in that case, you try to bring your wrist up, just like in tenodesis, and the fingers will drive into a tight fist. And so that one's relatively easy to learn as well. But when that guy is not available, now we're going all the way up to the arm, and this is the C5 injury patients. And that's a little bit tougher one. That's the brachialis muscle. We usually do this in a two-stage operation. We bring a graft down into the arm, and then we have to hook it up later on. If we can't get the fingers to open with the supinator, we can use that one and make that be the finger closer as well. So the C7 pronator operation, really simple. Just right here in the forearm, connect A to B, and that'll make the fingers close. And there's another graphic picture. This is the finger flexors. This is the pronator. And the nice thing about this one is there is a pronator branch just up above that. So we save the proximal one. They can still turn their palm down. And we take the bigger distal one, the one's a little further down the arm. We cut that, and it's a perfect size mesh. You swing him over to there, and that's a really easy operation, and it works very well. Okay, I'm going to pause for a couple of the questions that came up here. Is sensation restored along with movement after the transplant or just movement? These are just for movement. They don't provide any additional sensation. Most folks have not been excited about moving sensation around. So anytime you get sensation, you got to take it away from somewhere else. We can move sensation to the back of the hand. A lot of folks have retained sensation in the back of the thumb and the back of the index finger. We can take that and we can swing it over to the pinky finger. So people, frequently mid-cervical injuries have lost all sensation of the pinky finger. And then they get burns and we get problems with that. We can move sensation over there. I haven't pushed it hard, and most people, when I've offered it to them, have said, nah, I'm used to this, and we'll leave it alone. So really, we don't do a lot of sensory movement. How do I know if I need this surgery? So if your hands don't work and you can't pick up objects and feed yourself, then this surgery would help you. And what capabilities are and should continue to improve. So I recommend to other surgeons who've been taking on these operations, do not operate on somebody before 9 months after injury. I have over and over again had people gain a level of function within that 9 months. Usually they get it by 4, a few more get it by 6, a few more get it by 9 months. And it's very, very rare beyond that, but I have seen folks gain additional function even beyond 12 months. But now we're down to the less than 5% group. Insurance does cover surgery. This is now a standard of care situation, so that's not a problem. Copy of this presentation, I have given it so many times that if you jump on YouTube and punch in my name, you're going to find a variation of this. Are there options available for C? I'm sorry? I think I heard somebody asking a question.
It might just be some background noise.
Okay, good. And then somebody asked here, can you speak to the options available for C3? C3 is tougher. What if would you guys be able to find that one in you?
Sorry, is there somebody that isn't muted? I'm trying to.
I think I just got them.
Thank you.
Perfect.
Thanks, Ryan.
Okay. Options for C3 spinal cord injuries. So I almost hate to stick with the designations that are given at the rehab hospitals, because nobody matches the level that they're labeled when they come to see me. So let's say I'm a C3 or 4 injury and they're flexing their elbows. So you're not, you're at least a C5 if you're flexing your elbows. Or I'm a C4 and you're extending your wrist. No, you're not, you're a C6. You may have started at that level when you came in, but it's sort of easier to answer the question based on what function do you have retained. So If you can shrug your shoulders well, I can sometimes move a muscle to flex the elbow. If you have nothing, it gets really creative, but you can use a part of a nerve from the tongue or whatever to send that down to flex the elbow. But usually when you have nothing, the more you have, the more you can get. And if you have nothing at all, usually we go for stabilizing the shoulder and flexing the elbow, which is a big quality of life improvement for somebody who has no limb control whatsoever. Then somebody asks, is this only for people with spinal cord injury? And no, this was done for nerve injury long before we applied it to spinal cord injury. We've now been doing similar procedures for folks with strokes. Any number of, there's children who get inflammatory disorders that attack the spinal cord that can benefit from procedures like this. So this really is a procedure that's done across the board for all kinds of different paralyzing injuries. Next question was, in a geriatric spinal cord injury patient, 70 years plus, what is the type of risk-benefit analysis to determine if this surgery is a viable option? As folks get older, nerves grow slower and the results are less strong. So when we get to 70 plus, I sometimes lean more on the tendon transfers just because they're more reliable in that age group. But if somebody's really aggressive, a go-getter, they are going to rehab and they show you that we're going to do absolutely everything you ask, then I really don't limit by age. We do our best with the nerve transfers, and if we don't achieve it, then we can add tendon transfers to it to get everything we can. It really depends on how invested an individual is in getting the most function they can get. For some folks, the right answer is just get the thumb to open and close, and that's it. And that's good enough for them, and that will enhance their life, and that shortens the number of surgeries they have to go through, and that's all you want. But others say, I really want absolutely everything you can give me. You know, what's the menu look like? And then we'll do more. All right, and so this is just demonstrating what finger flexion looks like after these. And so this is that pronator to finger flexion operation. I'm going to use this also to point out another thing that we often fix later on is if you see the tip of that thumb right there, he's got great strength, but it's folding inside the palm. If we can straighten the tip of that thumb out, it would land right here on the side of the finger for a powerful pinch. And that is something that often I'm asking patients to do that afterwards, to get that thumb straightened out so they can land a powerful pinch, because that's where most of the function comes from. Here's another one, same procedure. Maintained a lot of intrinsic tone in the hand, but this is before surgery. There's kind of an enhanced tenodesis type grasp, and this is after surgery. Really tight hand, it opens up nicely. And because of the retained muscles in the hand, the fingers straighten out beautifully. This is using the supinator muscle. And they're able to, this gentleman was able to really get fine objects between his thumb and fingers there with a good grasp. He did not have available finger extensors for nerve transfer, which is why we use a supinator for the finger flexors, and it was a tendon transfer, which causes the fingers to kind of pull open when his wrist drops into flexion, but it's not the nice opening that we get with the nerve transfer. So then the next one is using the elbow flexion. So if you're a C5 injury, we don't have these nerves down here to use. We have to go all the way up above the elbow. And these are the same folks who need their triceps repaired. So usually the same operation is hooking up the triceps nerve. We come down the arm and we take a graft, we hook it up and we tunnel that graft under the skin and leave it in the forearm. So we give this 4 to 6 months to heal. And then at the end of that, we go open up the forearm, get the other end of that graft and plug it into the finger flexors at the same time as we do the other transfer for the finger extensors. So these folks with the C5 injuries have to undergo a 2-stage operation, one for triceps and the graft, and then number 2, do everything to make the fingers open and close at the same time. And that is the graft up top. And here's the graft going through the arm. And then we go, whoops. And then we go find the nerve later on. And this is the graft, and it gets hooked up to the finger flexion nerve branch in the forearm. And we've had lots of very strong results with this, but it is tougher to learn. So Amber here, our therapist, is resisting her flexing her elbow up or pulling the arm up towards the mouth, and that's what's initially driving the hand closing. And this young lady got a very powerful result. But you can see the clawing there, so she will need that repair of this joint later on. And you can also see that thumb. No, her thumb is okay. The other tough thing with this transfer, the elbow flexion for closing the hand and the supination for turning the palm up to open it, is your biceps does both of those. So some folks really have a hard time not contracting both sets of muscles at the exact same time, and that will drive you into a more dramatic claw. So it really takes some sitting down and making sure I can turn my palm up without flexing my elbow up, and I can flex my elbow up with the palm facing down so I can separate those functions. So that's another reason this is not my favorite transfer, but I've had a number of patients who really have done well with it. A couple more questions here. Can this surgery help incomplete spinal cord injury C1 to T4 injury? Yes, it can. So when you're incomplete, we've got another set of challenging questions, which is the spastic muscles sometimes have some control. And so we have to go in there and figure out which ones are well controlled and which ones aren't, and can we just make it work better with what you already have before we do a full transfer. Sometimes we just move muscles into a different position. So I lean a little bit more heavily on tendon transfers in the spastic incomplete setting, but sometimes nerve transfer is the right answer there too. And it's really very individual. So we want to see them and examine them, and then I can sort of put together a menu of what I think we can accomplish. The next question was, do you perform surgery on bilateral upper extremity with one surgery or two? I like to separate those out. The reason I separate those out is because when you're doing microsurgery for hours on end, it becomes your skills tend to drop off by hour number 9. And so I would rather have these as a 5 hours or less in the operating room and then have my hands ready to go again the next day to do the other nuanced operations. Doing 12 hours of nerve transfer, I've done that to myself many times, and my skills are just not as good at the end of 12 hours as they are at the end of 4 or 5. The next question is, does it help with tone? And yes, it does. So every muscle that we address with the nerve transfer, it no longer has spasticity. The spasticity in that particular muscle is gone. We can also specifically address other muscles. So one of the things we'll run into with patients is tenodesis grasp, and this is an important conversation. Now, tenodesis grasp, which a lot of folks will have before surgery, once I cut that nerve, the fingers become floppy and that tenodesis grasp is lost. So you may become more dependent after surgery than you were beforehand, but that's replaced with much better function by the time it grows in. Sometimes the other muscles to the fingers are there and they're spastic, and I'll leave them in place so that they can maintain a tenodesis grasp. When everything starts working, then they say, now it's just getting in the way, and then we can go back in and address that spasticity later on. But if I can keep you functioning during that waiting time for the nerve transfers to work, I prefer to do so. So next question was, can you tell us a little bit about nerve transfer versus sensory nerve damage in the lower extremities? All right. Yeah, lower extremities are tough because most of the folks who come with legs not working, the injury level is quite high. And so to reach a functioning nerve from above the level to the nerves below the level can be, you know, 1.5 feet. These are not easy transfers. So it can be done. They're bigger operations. And the question usually is it worth it? So we can take sensation that goes to the inside of the forearm and extend that down to the lateral thighs. It takes grafting. It takes a 2-stage operation, and it works. You'll touch the thighs. You'll feel it in your forearms. You say, hey, now I have sensation there. But are the side of the thighs the most critical area to put sensation? And that's kind of an individual question. Some folks have talked about wanting sensation down to the genitalia area, and it can be done. It doesn't feel normal. You feel it in your arms and so forth. It's not something people have usually pushed hard for, so we have not done a lot of those. How long does it take to get an appointment? We're usually pretty quick. I would say within the month when they call for an appointment, they usually, the bigger problem is fighting with insurance to get approval. Because insurance will usually say, oh, if they're coming from out of state, oh, I'm sure there's somebody in New York or Connecticut or New Hampshire or Maine or whatever that does this. And as far as I know, there isn't anybody else doing this in New England. And so then you have to have the primary care doctor fight with insurance and say, this is the only provider who does this, and then they'll get approval and come through. So from our end, we can schedule it right away. From insurance end, it often can be a fight if they're coming from out of state. How do we begin the process of getting consultation assessment? Just call the office. Italo has been fabulous. He started with us just a few months ago, and he's really on top of things. So the number 844-930-1001 is the office number, and you can just call that, and he can get anybody started.
Good. Looks great.
All right, so. All right, and so this was the very first one we did with the sterile graft down the arm, and she's sent me videos later on. So that's the brachialis. Her arm is not lifting off her lap. She learned to close the hand very well with that. And then this is the kind of thing we shoot for with everything we do. So he was a high C5 injury. He did the triceps operation. It wasn't a powerful triceps, so he was able to stabilize himself. He was chronic. So the denervated finger extensors, you'll see the last two fingers don't extend well. And that's because of the damage in the spinal cord. So he was on the borderline of, hey, this isn't going to work for these fingers, but it probably will work for those. When we put the stimulator on him, the thumb and index finger open up nicely. The last two fingers didn't open. So we'll do the same transfer, but I guarantee you only the first two fingers will work in extension. And then we did that graft from above down to the hand for fingers to close. And then we did our tendon work for the thumb. And so this was the end result of somebody really pushed through to get everything done, who had no finger movement at all beforehand. So you can see he's really dependent just on the thumb and index finger. But his thumb positions well, he extends nice, he can get around small objects and big objects. And just having those two fingers for him has been just a huge quality of life enhancement. There's really nothing he can't do with those hands. So, and now we've moved into injuries that were not ever considered for reconstruction previously. So this lady comes from across country, and when we met her, she had trace wrist extension and nothing else. And I thought, gosh, what are we going to do? I wanted to reinnervate her wrist extensors, but they were denervated, so it wouldn't work. And so I went for finger extensors, and then she came back and she had this hand where the finger extensor transfer is working, but it doesn't translate in any useful function. So she was entirely dependent. She's got a great husband who cares for her, but there was nothing that she could do with her hands at all. So she really stuck with us, and we said, let's just get all the function we can down in the arm, and then we'll figure it out from there, whether we can move tendons around to make this work a little better or not. So she did the brachialis graft down to the hand to get the fingers to close. She did the then the distal hookup. She did the supinator to PIN one, and then she got fingers that opened and closed. And then we said we want to correct that claw. And we usually start with the lumbrical bar splint to make sure that we can get those fingers to extend the IP joints. The surgeon will work, get them to say, yes, this is helpful to me. Then we went on to surgery to bring those joint capsules down. And the great discovery was that once you got these knuckles flexed here, that the finger extensors now extend the wrist also. So she ended up being able to get her hand wide open and to get the wrist to extend all with the same movement. So just one set of muscles is doing all kinds of functions there. So she went through a couple of years of reconstructions and got to this point with some innovative therapists on her end who would brace the elbow flexion so she couldn't bend the elbow, and that would force her hands to flex. And so there was really a lot of training that went on, and she was committed to this. And then within a couple of years, she had hands that hadn't worked at all.
different sizes that you can do. I mean, Dr. Lee's.
And now they're all working quite well. And she, again, entirely insensate hands. And this is something that the orthopedic surgeons used to say, is if your hands don't have sensation, don't bother reconstructing them. Her hands have no feeling whatsoever. And here she is picking up blocks and putting them down. And she's become very independent. And she sent us not too long ago, all the self-care she can do. So she's picking up her hairbrush and stabilizing it with the other hand. And she can get up here and comb her hair. And she gets a little assistance on getting the mascara out of the container there, but she's able to do that as well. And so on a person that they would have said this is not worth trying to reconstruct, you cannot get anything good out of this. Adding the nerve transfers to the tendon transfers with the other finger repositioning, we were able to really get her a lot of independence, and was very, very happy with that. Got another question here. Looks like we have a repeat of the question we answered a little bit earlier, but now it says, oh, please share that number after this meeting. Yes, we'll do. Okay. And this is just an article by Steve's back in 2012 that talked about the kind of care folks require based on their cervical level of injury. So we know anybody C4 and above requires total assist 24 hours a day. When we get down to C5, he said, some of these things they can help with, like bed mobility and pressure relief and eating, dressing, and grooming, but everything else is total. But as soon as we got to the C6 level, there was all this independence. And once we got to 7, 8, again, that grew again. And we are able to make this transition in a lot of folks. And the lady we just showed you, she was here going to here. I mean, the amount of self-care that you're able to do after getting those hands to open and close and pick objects up is tremendous. You can start using your cell phone. You can start calling folks. You can, feed yourself. You can use your own catheter. It really makes a huge difference. There's a number of things we do for patients who've had a brachial plexus injury. One arm is paralyzed, and we do what we can to get that arm back. They have another good arm, so they can do everything. They're just, inconvenienced by one arm not working. But the spinal cord population, you don't. Both of those arms are equally affected, and you really are totally dependent on other folks until you get them working. So this is probably our favorite population to work with. And I feel like it's a place where we can sort of make the biggest difference. I think we can stop there. This works in babies, and we've got other things we're doing research-wise. But let me stop there open up for questions.
Thank you so much. We've got sorry that I put a repeat question in there. I didn't mean to do that.
Oh, no worries.
Yeah, so I'm going to, if it's okay, I'm going to just take you off of, I can figure it out. I'll do it in a second, just so I can see everybody. If we have anyone else who's got questions, who wasn't able to put them in the chat.
So you'll want to talk, if anybody's considering doing this, talk to the folks who've had it done. There are some inconveniences, particularly when it comes to the tendon transfers. The nerve transfers, I know lots of people disobey all my restrictions and somehow get their function anyway. The tendon transfers are a tougher deal. They can pull apart. They do require a lot of therapy. They do require braces and this sort of thing for 6 weeks, sometimes up to 3 months. And that's not fun to have your hand tied up for 3 months. But anyhow, all right, somebody put their hand up. Warren?
Yeah, actually, I gave the question about the geriatric population, but I'm a C5-6 spinal cord injury patient. But in the process of my injury, I also was diagnosed as having ulnar nerve damage,
Okay.
which has caused my right hand to have these 2 fingers.
Okay.
And although I can use this hand and I can move the arm and everything else, I went to an orthopedic surgeon who wanted to do the ligament surgery related to this hand. But I didn't know if there was any type of nerve transfer surgery that would benefit an ulnar nerve damage scenario.
Yeah, so the hand is you're demonstrating right now has that clawing that we talked about in the video,
Yeah,
particularly the last two fingers. And the right operation for that is the one that I showed where you bring those knuckles into flexion and that will straighten those fingers out. So we can do that. I'm sure that orthopedic surgeon you saw, you can do that, but that really should make a big difference for you to get those fingers straightened out and in a better position.
okay.
The nerve damage situation, we're kind of talking about that at the beginning of the talk. If the nerve has been paralyzed for, beyond 18 months or 2 years, we unfortunately can't really fix the motor part of that. We sometimes can get sensation back. So if the ulnar nerve is damaged, we can repair it and get some more feeling back in your fingers, but I don't expect we'd be able to wake up the muscles that are associated with the ulnar nerve. Now, just for the community as a whole, folks who are living their life in a wheelchair tend to beat up their ulnar nerves, and it's underdiagnosed because most folks with a cervical injury are already numb in the last two fingers. If you get number or you're developing a hand weakness that progresses over time, that's always worth looking into, because if you live with your elbows bent and you're bumping them against a chair, that's the funny bone nerve, and he's very vulnerable to people who live in a wheelchair.
Thank you.
Yes, Seth.
Doctor, I had to step away for a few minutes to sign for mail. Did you answer my question regarding anything you might know about nerve transfer surgery working for sensory deficits in the lower extremities?
Yeah, so we did talk about that. Depending on the level of injury, a lot of times folks are coming to me with a T4 injury saying, can you make my legs sensation come back? And boy, it's hard to get a nerve from way up high to down low, but you can do some.
Wow.
So we can take the sensory nerve that goes to the medial forearm here, and
Uh-huh.
that can be run down the chest wall in a two-stage operation, and we can put it into a very select area of the lower extremity. So we could put it to the sides of the thighs is probably the easiest one, and that's one that's described in literature. The question is, when we're all done with several stages of surgery and you touch your thigh and you feel it in your medial forearm, and it's kind of, it's not going to be normal, it's going to be faint, will that have been worth it? And I like to sell people on things that I know at the end you're going to say, wow, thank you so much for doing that, versus I put you through 4 operations, you say, I'm not sure I'd do it all over again. And that may fall in the category of
Well, is there anything else you can say if I tell you my injury is T7?
Okay.
Would that change things much or not?
Not a whole lot. I mean, so and again, anytime you're putting something somewhere else, you have to take it from somewhere. So the intercostal nerves that do the chest wall, they can be moved and put on a graft to send down lower. They can be moved to the thigh. So we're going to make you more numb in your chest in order to get some lower quality sensation in the sides of the thighs.
Well, I'm actually more concerned with terribly numb feet, being
Okay.
able to feel the ground.
Okay. Well, let me ask you this. If it's just the feet, do the legs have feeling to them?
The legs have sufficient feeling. It doesn't, I feel fine with the legs.
Okay.
It's only the feet that really, have an impact upon my ability to walk.
Okay. So you could move leg sensation to the feet. Again, it's not going to be quality sensation, and we do have to take it out of the legs to get it there. The skin sensation fibers, although you will feel a poking in the bottom, it'll be an unusual sensation. You'll initially perceive it in the leg where we move that nerve from. It probably won't provide the proprioceptive feedback that you need for better balance. And that would be the downside. So usually when you're having trouble walking with lack of sensation, it is the sensory part of the motor nerves that aren't giving the feedback to the spinal cord. And that's something, unfortunately, I'm not good at fixing.
Well, I don't want to take up too much time, but you don't happen to know of any other surgeons who do specialize more in that area, do you?
I don't.
see.
At Mass General, there's a couple guys in plastic surgery that you could certainly talk to.
Oh,
Jonathan Winograd, would be one, and Kyle Eberlin. And it just you can, get other people to pick their brains and see if they come up with things that I didn't come up with.
Okay,
Always, what's that?
I was just going to say thank you very much. That's very helpful.
Yeah, absolutely. So it's always, and this is across the board with anything in medicine, get second opinions. I mean, there's things that we're expert in, but it doesn't mean other people don't have ideas that we haven't thought of. So I think it's always worth going, talking to somebody else and see what they've done and so forth.
Okay, thank you very much.
Yes, sir. Shanita?
Hello?
Hello.
Hey, so I saw this on an SCI Boston flyer. So I'm assuming this is in Boston. Is there anything in New York?
Well, plenty of New York patients are coming to us. There unfortunately isn't somebody doing the procedures there that I'm aware of. We do have a collaboration with a rehab center down there that we're working together. We've got a study with them, so we could certainly, do surgery up here and send you the folks down there for rehab. But I don't know any surgeons that are doing this in New York. For the nerve transfers, it really is okay to travel because there's not as much maintenance involved and post-op care and so forth. These are outpatient procedures. You can head home within 2 days of the operation. The tendon transfers, I feel a little less comfortable operating on you and sending you away because they do require lots of oversight. Yeah.
SKF.
Hi, doctor.
Hello.
I'm a C3C on the Asia scale. I was injured exactly 2 years ago today.
Okay.
And you're saying that recovery can end after 18 months, but I'm still recovering and making great strides. I'm working closely with folks in your hospital as well as Journey Forward. Do you think that, so my question is, could I be recovering still in my nerves, even though I'm 2 years out?
So are you a complete injury or an incomplete injury?
Incomplete. They originally diagnosed me as complete at C3, but I have proven them wrong.
Perfect. Good job. The incomplete injuries can be a little bit more ambiguous on their recovery. And so when you can communicate from above the injury to below the injury, then there's lots of opportunity for what they call plasticity. So if you can do just a little bit of twitch and movement, that can grow over time, even over years, into achieving greater movement. And if you move one little muscle, it can then move on to moving several muscles, and then you learn how to balance those better and so forth. So that is a group that I would say can have much later recovery. I have even seen in the complete injuries late recovery. It is much, much rarer than in the incomplete injuries, though.
It's easy for me to come to your office. Does it make sense for me to schedule an appointment?
Sure.
Will do. Thank you.
Yes, sir.
Great. We have last question, Josh.
Yeah, sorry to jump on.
No, go
just want to
ahead.
say thanks, Dr. Brown. The presentation was awesome. I'm a C4 quad. I function more at C5 on my left arm.
Yeah.
But I have a brachial plexus injury in my right arm from a bullet.
Okay.
And I actually met with Dr. Eberlin back in 2017, and he had recommended at the time a gracilis transfer. I'm curious with the brachial plexus injury, would you even consider nerve transfer options in my right arm or?
Yeah, so that's that story we keep coming back to is the nerve related paralysis. So the muscles that have been lost because the nerve's not talking to them, they undergo that degeneration. So after a year and a half, like 18 to 24 months, they have become irrecoverable. And that's where that gracilis option comes in. So we don't have muscles that we can retrieve by connecting a nerve to them, but we can go get a muscle from your leg and put it in there and make that work. And I work with Eberlin, and we do one of these gracilises about once a month, usually in the context of brachial plexus injuries.
Okay.
Yeah.
Awesome. Thank you, doctor.
You bet.
Great. It is 12 o'clock. Dr. Brown, you may have, your administrative assistants may be very busy on Monday.
Okay.
But we're really so grateful for you to take the time to talk with us. We had a really wonderful turnout and lots of people that asked if this was being recorded so they could view it later, which it will be. And was there any final questions that anybody had? I just don't want to miss anybody if there was something.
Yes, I had one. How many days of recovery after surgery would you be okay to leave the hospital?
Oh, these are mostly outpatient procedures. So you're going home the same day.
Oh, okay. Even
Yeah.
if it's the nerve or the what was the other one?
The tendon?
Yes.
Yeah.
Either or.
Yeah, either or. So the one that's different than that is the one that Joshua just mentioned, that gracilis transplant. That is, oh, you know, a less than 10% that we're offering that to folks because it's a big deal operation. That one you live in the hospital for at least 5 days. But just about everything else we do is relatively quick, outpatient, go home the same day. Pain's not bad. If it's nerves, there's very little mobility restrictions. If it's tendons, we put you in a splint and we're going to work with OT and keep a close eye on you for the next 6 weeks.
Great. Well,
Thank you so much.
Yeah, and thank you all
Absolutely.
for attending. If you have anything that SCIboston can be helpful with, please never hesitate to reach out to me or anybody on the team. And I think we will wrap this up. And again, thank you so much, Dr. Brown. This was fantastic.
You're welcome. Good to meet you. Thanks for having me, guys.
Thank you.
And again, this really is our passion. This is our favorite patient population. This is what we love to do. So anyhow, I'd love to meet any of you.
Wonderful. All right, everybody.
Bye-bye.
Bye. Have a good
Bye.
day.
Much.
Have a great
Have a good
weekend.
one.
Thanks so
Thank you.
much.
Bye-bye.
Yeah, and if anyone needs information, you can contact me if you need some contact info.
Thank you.
Thank you.
Yeah.
Bye-bye. Bye-bye.